I'll share my screen right now. Give me 1 second. All right, and then we'll share this. View one page. All right, so as I take over, the system is adjusting. Please let me know if you see the pending minutes from previous meeting.
It's visible.
That's visible.
Yes,
Perfect.
it's visible.
Thank you, everyone. So a couple corrections we would like to point out is under A for information, we would like to correct medication use in adults. It wasn't for children. And then second, there's a couple corrections that you see below that. So it's going to be the recommendations that were all agreed upon. So I made a quick summary of that on a slide I'll present later. But one is requiring a prior authorization for stimulant agents in patients under the age of 4. That was one. The second criteria was concurrent use of 3 or more stimulants within the same drug class, amphetamine or methylphenidate drug class. And then the third one was concomitant cross-drug class stimulant utilization for more than 30 days, amphetamine and methylphenidate or vice versa. And then we're also setting the maximum quantity limits based upon the FDA recommended maximum daily dosages or approved compendia. And then I could show you a slide of, just to make it a little bit better for the eyes. Where is that slide? Okay, that's loading. Can you guys see that slide, the recommendation slide?
Not yet.
No, we just see your handsome face.
It's the same one that's on our email, right?
Yeah, how about, I believe so, but let me double check. Entire screen, maybe I can just do that screen too.
There it is.
Okay, so this one's just a little bit easier to read about the recommendations that were agreed upon from the previous meeting. So one is requiring, like I mentioned, the prior authorization for patients that are under the age of 4, and then establishing the high dose product quantity limits based upon the FDA recommended dosage or maximum daily dosage or clinical evidence approved. Requiring a prior authorization when using any of the following combinations. One is concomitant cross-drug class stimulant utilization for more than 30 days. The reason why we chose more than 30 days is the way this, well, patients could be started on one drug and then stopped and then started a new drug. So what we're trying to do is catch the patients that utilize both drugs, and one from the amphetamine drug class, and then also one in the methylphenidate drug class for more than 30 days. So we don't require a PA for patients who are just transitioning over to medication. And then lastly, a use of 3 or more stimulants within the same drug class, and that's going to be within the amphetamine or in the methylphenidate drug class. So those were the modifications we would like to make to the minutes there.
Move approval. That's Dr.
you.
Lynch.
Thank you. Is there a second?
I'll second it. It's Neil.
Great, thanks, Neil. All in favor?
Aye.
Say aye.
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 right,
you.
the minute stand is approved. Are there any additional housekeeping items?
Yes, there are two housekeeping items. One is the gabapentin and pregabalin safety edits became effective beginning of April 1st of this year. So that, remember, it was a maximum dosing for gabapentin, 3,600 milligrams for gabapentin, and then the max dosing for pregabalin was 600 milligrams. And then also we prevented the concurrent use of pregabalin and gabapentin, so that also took effect. The second item was the 85% refill tolerance for controlled substance also became effective beginning of this month. Those are the two that I had. Is there anything else, Jennifer?
No, nothing. Nothing more than that. Thank you.
No problem. Thank you.
All right, can we get the PNT committee update from Brian Larson?
Yeah, we canceled our March meeting. So we've postponed that meeting. We'll be holding that in May instead. And just a second while I pull that up. So the agenda will remain the same. We'll be discussing the cystic fibrosis gene therapies, the CAFTR drugs.
Great. Thank you. Okay, I guess the next item on the agenda is the review of the opioid use disorder treatments in pregnancy.
Good morning, can you hear me?
Yes.
This
Yes.
is Valerie from the University of Utah. Before I start, I'm going to go ahead and just point out a couple abbreviations that I'm going to be using during my talk. So I'm going to use ASAM, which stands for American Society of Addiction Medicine. MAT, which stands for Medication Assisted Therapy. OUD, standing for Opioid Use Disorder. And SAMHSA, standing for United States Substance Abuse and Mental Health Services Administration. So opioid use disorder is a chronic relapsing disease for which treatment access is a priority of national and state health departments. Significant reductions in opioid overdose mortality occur when patients are treated with medication-assisted therapies versus no treatment, yet only about 1/10 of those with OUD receive treatment. Medications for OUD help reduce cravings and blunt or block effects of opioids. Treatment is associated with reduced opioid use, reduced criminal activity, and reduced IV drug-associated infections. Naltrexone is additionally approved for treatment of alcohol dependence, unlike the other OUD medications, buprenorphine and methadone. Longer treatment duration with these therapies is associated with improved outcomes. While the report provides further background information, my presentation will touch on information regarding treatment during pregnancy, MAT plus concomitant opioid prescribing, and the current PA and quantity limits for oral buprenorphine products. Untreated OUD leads to poor pregnancy outcomes, including less attendance to prenatal care, spontaneous abortion, premature birth, and fetal abnormalities. It has long been viewed by experts that the benefits of agonist therapy outweigh the risks. Both methadone and buprenorphine are recommended for the treatment of OUD during pregnancy. However, since drug metabolism increases during pregnancy, increased MAT doses or split dosing flexibility is needed for this population. Both the single ingredient and combination oral buprenorphine forms are considered safe and effective for use during pregnancy, according to the newly released 2020 American Society of Addiction Medicine guideline. The injectable long-acting MAT products are generally not initiated during pregnancy, but for a patient who has already stabilized onto one of these agents prior to becoming pregnant, guidelines state that the decision of whether to continue use of the product upon becoming pregnant should be made in consultation with their provider. As metabolism increases, especially in the second and third trimester, prescribers may transition patients off long-acting buprenorphine to an oral formulation with more dosing flexibility. There is no recommendation for an involuntary therapy switch at the time of becoming pregnant. Regarding the experience of pain, experts of addiction have described that patients on MAT therapy are not immune to pain from trauma, acute medical illness, chronic diseases, surgery, etc. Stigmatization may lead to patients in this population being inaccurately judged as drug seeking as opposed to pain relief seeking. The SAMHSA guideline states that inadequately treated pain may be a trigger for illicit drug use. For patients that are on OUD therapy, the following strategies can be used to treat legitimate pain, but these are secondary to trying non-opioid therapies. With methadone, the dose or administration frequency can be increased. With buprenorphine, an increase in dose by 20 to 25% or split dosing can be tried. However, some patients with severe pain may need to be switched off of buprenorphine to a full mu agonist. Or the addition of a short-acting opioid may be added to buprenorphine in a supervised setting. And with naltrexone, particularly the long-acting product, I'll just mention that any attempt to override the antagonist action with a high-potency opioid should be carried out in the inpatient setting, according to the ASAM guideline. For the management of co-occurring pain, ideally an addiction medicine and pain medicine specialist should be involved if available, especially for those with chronic pain and OUD. Also, prescribers of MAT and opioid concurrent prescriptions should be in coordination with one another. When considering policy actions regarding overlapping fills of MAT medication and an opioid, we should consider that the sequence order of these fills is an important factor and can reflect very different clinical scenarios. Expert committees such as ASAM generally recommend continuation of MAT even if the patient has an episode of opioid use, since MAT therapy is protective and better than no therapy. Efforts to avoid disruptions to MAT therapy should be considered, since involuntary discontinuation or even a temporary disruption to access of a patient's MAT therapy can increase their risk of overdose and other morbidity-related outcomes associated with untreated opioid use disorder. I'll now move on to addressing the current controls on oral buprenorphine products. But I want to point out there is considerable access to these therapies, considering that there's no prior authorization criteria in place for Suboxone or the long-acting injectable therapies, Sublocade, Probufene, and Vivitrol. Other oral products can be obtained via prior authorization. If the board decides to maintain the prior authorization for a subset of therapies, potential areas for modification and discussion are summarized on page 38 of the report. You may wish to consider omitting the requirement for recurrent reauthorization and documentation of psychosocial support or plans. Additional patient scenarios where the use of a single ingredient buprenorphine product is indicated can also be considered for addition. Table 6 of the report on page 39 summarizes current quantity limits and their implications regarding patient-specific needs during the induction and maintenance phases, or scenarios where providers may wish to increase doses or use divided daily dosing to treat pain. Most patients are expected to stabilize on doses of 24 milligrams per day or less of buprenorphine. However, individualized dosing approaches may apply for scenarios including rapid metabolizers or if being treated for legitimate pain. Prescriber rationale could be considered for these occasional cases. Point of sale restriction should be programmed carefully to minimize catching false positives, since there can be detrimental effects caused by halting the patient's access to their maintenance medication. Given the treatment gap among the population with OUD, addiction treatment experts and national associations such as the AHRQ, the American Society of Addiction Medicine, and the American Medical Association's Opioid Task Force advise against prior authorizations that create barriers to OUD pharmacotherapies. Their emphasis is geared toward focusing on retaining patients in care. Nonetheless, as these therapies become more widespread, it is important to review utilization since agonist therapy is not without abuse and misuse potential. Retrospective provider outreach could help address potential gaps in MAT care and/or where vigilance around safe MAT prescribing can be encouraged. And that's all I have for today.
Great, thank you.
Thank you.
We also have a slideshow present to piggyback off that. So hold on, let me share my screen now. And then you should see the slides. Let me know when you see those.
Got it, Mo.
We can see them.
Thank you. Thank you. Thank you. All right. So piggybacking off of Valerie's report and also her talk real quick is we're going to be be touching on the Support Act, the maximum MAT dose recommendations, the prior authorization form update recommendations, consideration for future policy, and then quality, performance, continuity of therapy for opioid use disorder. And the last two bullet points Jennifer will be discussing. So moving on. So the Support Act addresses many aspects of the opioid epidemic, such as treatment, prevention, recovery, and enforcement. One particular section I would like to focus on today is Section 1006B, and that is MAT coverage requirement. So this section indicates that all Medicaid programs must cover all FDA-approved medication-assisted treatments beginning of October 1, 2020 through September 30th of 2025. This also includes counseling services and behavioral therapies. Prior to the MAT coverage requirement taking place, the Secretary of Health and Human Services will provide recommendations to improve Medicaid coverage and payment for MAT. So as of yet, there has not been any published CMS guidance. And to aid the Secretary in providing recommendations, the Support Act requested multiple reports to be conducted by the Government Accountability Office, or GAO, and Medicaid and CHIP Payment and Access Commission, or MACPAC. So one GAO report assessed the barriers to Medicaid beneficiaries' access to treatment medications. So within this report, they referenced a SAMHSA 2018 report that indicated all 50 state Medicaid programs were covering oral MAT. The GAO report also indicated that there were 12 states that had laws to prohibiting prior authorizations for substance use disorder medications. One MACPAC report assessed the utilization management of MAT and Medicaid. Within this report, they referenced a 2018 report that found 30 state Medicaid programs that required a prior authorization for at least one MAT. This report also indicated a trend was observed in reducing prior authorization use among Medicaid programs for MAT. So overall, the reports do provide valuable information that Medicaid programs are continuing to improve access to MAT. And this is seen with Utah State Medicaid program as well. And beginning of 2019, the PA was removed for Sublocade and Vivitrol. And at the beginning of this year, the PA was removed for Suboxone. Moving on to buprenorphine dose limit and exception criteria. So Utah State Medicaid's goal is to encourage appropriate guideline-aligned use of medication. One area that we would like to discuss is the dose limit for buprenorphine, which is currently 24 milligrams per day. As you can see, the American Society of Addiction indicates there is limited evidence regarding efficacy at doses greater than 24 milligrams per day. And they also indicate that there may be an increase for risk of diversion. And then there's also similar wording seen within the manufacturer package insert, but this does not indicate there is similar wording within the manufacturer package insert. With that said, from Valerie's report, there are times where a higher dose may be warranted, and that is short-term management of acute pain in patients with opioid use disorder diagnosis, pregnancy due to higher clearance rate in the later trimester, patients who are rapid metabolizers confirmed through genetic testing, and patients who concurrently take CYP3A4 inducers, which lower the buprenorphine levels within the body. So our prior authorization recommendations are: 1, allowing those patients that we just discussed to exceed the maximum dose and quantity limits that we have. And once again, to the left is what we have currently, and then to the right is what we recommend changing. So right now, currently we have a buprenorphine max dose of 24 milligrams per day, and then based upon that, the quantity limits are set. So what we recommend is allowing patients to exceed that maximum dose, and then also quantity limits for patients for acute pain management, for the patients who do have an opioid use disorder diagnosis, pregnancy, rapid metabolizers, and then also patients who are concurrently taking drugs that are CYP3A4 inducers, like carbamazepine, phenytoin, phenobarbital, and so forth. Another one is details of psychosocial support members receiving and treatment plan. So based on Valerie's report, we do see that there is a consensus of allowing patients to receive single ingredient buprenorphine products. Going back. So details of the psychosocial report, there is a consensus report that should not be a requirement for these patients to receive therapy. So we would like to not have that as a requirement anymore, as based on the new guidance. And then lastly, we would also like to consider patients to receive single ingredient buprenorphine for an induction phase when they are going off of opioids, and then starting the induction phase with single ingredient buprenorphine, and then also for patients who have hepatic impairment.
Okay, so Mo, if you want to move forward, I think to the next slide, I'll just talk for just a few moments. So, this is the older slide. Let me pull down this slide deck real quick, Mo.
Did you need this one?
Yeah, okay. So go ahead and go back real quick. So what we have today, so a couple of things that we're touching on with our presentation and policy considerations today. First of all, was that Medicaid has worked to open access by removing prior authorization barriers for MAT over the past couple years. In addition, we're now considering, as Mo presented, increasing dose limitations around single agent buprenorphine. One of the other considerations that we've had is concurrent use of MAT with opioids. So currently in our system, we don't have any edits in place that limit an individual who is being prescribed MAT, a concurrent opioid. And this is something we've discussed in detail because Valerie's review and the presentation within the university's report would show that this is something that is happening. And there were 246 patients, I believe, 248 patients who filled an opioid within 30 days of also receiving buprenorphine or naltrexone. And that if a person is being prescribed MAT as part of their opioid use disorder treatment, what are the considerations we want to have. Now, the prior recommendations would be that there is a opportunity for potentially up to 14 days of acute pain management for people receiving opioid use disorder treatments. So for those who are on chronic MAT, there may be a time when 14 days would be needed if a procedure happened or, there was an event that occurred that had pain. And that is something we want to think through. But as we consider putting policy in place to limit concurrent use, what we know, first of all, is that MAT is carved out to fee for service. And because of that, we, for ACO claims, we're receiving all of the MAT therapies. However, the opioid claims process on the ACO side. So that would be one limitation of implementing one of the edits within the point of sale system. Also, in addition, methadone is dispensed through the outpatient treatment centers, and it doesn't run through the point of sale system as it's dispensed in the OTP setting, and it's also not reported in the controlled substance database. So as a result, when we consider putting an edit in place that would limit the concurrent use of MAT and opioids, we know that methadone claims wouldn't adjudicate properly because they're not in the point of sale system. And then even if a prescriber is to go in and say, oh, is this person, I'm ready to prescribe opioids, I'm checking the controlled substance database, methadone isn't reported in the controlled substance database for opioid use disorder. So that would not be something they would see. It's a blind spot. So another limitation we wanted to point out. And then last, naltrexone has become a very popular treatment because of its ease of use. It's an injection that can be just administered once a month. And at this point in time, naltrexone is dispensed through both the point of sale system as a part of a white bagging process from pharmacies to the provider's office, and it's also open on the medical side through the buy and bill. So we see a fair amount of naltrexone dispensed through both means, but that would also be another limitation if we were to put an edit in place. And we know that with naltrexone, one of the things that we've been concerned about is that, first of all, if an individual is prescribed opioids while they're on naltrexone, obviously that effect is going to be blocked. But when naltrexone wears off, there is that risk of respiratory depression and severe harm for people who are to use opioids. And there have been reports of death when that naltrexone wears off. And anyway, this is another safety concern and something we'd love to do with regard to considering if naltrexone is dispensed, restricting concurrent opioid use. However, because it's dispensed on both sides of our system, that would be another area where we would have to consider working through that. So those are some things we'd like to talk about, but just moving into the next couple pieces of our policy and just our current standards. One of our strategic goals is to, if you could move to the next slide, Mo, is to assess continuity of therapy for those individuals who have been prescribed MAT. And this has been on our quality radar for a couple years now. Is something we're following. Now, when we look at continuity of therapy, this is assessing continuity of therapy for the entire Medicaid benefit, not just the fee for service. And so this is looking at patients on both the ACO and fee for service side. And this is a standardized measure developed by the National Quality Forum. And what this looks like, the measure description down below is the percent of adults 18 to 64 years of age who have a prescription for pharmacotherapy for opioid use disorder, who stay on that for 180 days of continuous treatment. So it looks at claim fill at the pharmacy. In the denominator, in order for someone to get into the measure, they just need to have one claim for a medication for opioid use disorder. And then the numerator is the individuals who have at least 6 months of continuous pharmacotherapy without a gap of more than 7 days. So they do allow some flex if they're a couple days late in picking up their prescription or receiving the medicine. The one thing that this measure does look at is when we look here at the top presentation of individuals who are in this, it is looking at single agent, but the measure does allow, and you'll see in the next slide, it does allow cross coverage. So it follows the patient. If I start on methadone but switch to buprenorphine, you'll see our overall rates are higher than rates presented here. But one of the things that we're interested in as a plan is looking at individuals who are, first of all, received any treatment type. You can see our overall continuity of care is about 41%. But when we break down by the individual agents, we see that the performance is different. Now, as Val presented, we know that individuals do better, and the data will show that patients do better when they receive concurrent therapy of medication in addition to psychosocial counseling. Now, that is why our prior authorization today does have that requirement for psychosocial counseling, and that is being given in addition to the medication. However, we know that there's long wait lines today, or access to care has been an issue with getting patients in, so that is a consideration for loosening some of those recommendations. However, we do find that overall methadone performance does do the best of the agents that are available. Okay, if you can move to the next slide. So the next slide then, when we look at continuity of therapy for this, overall average duration of use for our members who qualify for this measure is 202.8 days. And then we also see that there is a high percentage of patients who receive one script and then that's it. So we have, about 14% of clients who receive one dose or one prescription and then don't get a repeat script. And I think that's understood with this disease that may happen. Now, when you look at the overall utilization breakout, just to finish up with this, when you look at individuals now who receive buprenorphine versus methadone versus naltrexone, we can see here the percent of recipients who receive different treatment types and how they account for the percentage of claims and the days treated. And so one thing that we have considered is, how we can improve continuity of care by removing barriers such as prior authorization. And the next is partnering more closely with our treatment centers and our prepaid mental health plans and other partners. And I think this is even potentially one of the goals of the integrated model, is looking at how we can improve overall health outcomes and continuity of care. As we know, patients who stay in therapy seem to do better with regard to their social aspects of life and their other health measures as well. So just to present that, and I think now we're ready to move into a discussion. So sorry, we covered a lot of ground in that, Catherine. And I think overall where we are today, but where we are today, first of all, is that I think Medicaid has moved to removing prior authorization barriers. And we also know that the Support Act, effective October of this year, is to open up access to all forms of MAT, which we have available today with our preferred and non-preferred drug list. The non-preferred medications will still have a prior auth because of just the non-preferred status. But one of the considerations today for the board is to look, first of all, at our max dose requirements on buprenorphine, and then to implement some exceptions where the literature would support higher doses, of course, with clinical documentation. And Mo, I can hand back to you to do this piece. So.
Sweet, thank you. So going back to the recommendations that Jen and then we also discussed earlier. So these are the recommendations that we propose to move forward with.
Anybody have any questions?
So this is Eric. I mean, I guess help me understand. I mean, I guess I'm seeing a couple conflicts that exist in between the ACOs and the state on the fee-for-service side, where we're covering the opioids and MAT is covered by the state. I mean, that may be something we want to take up with the legislature as the ACOs and the, the health department combined. But I guess in the meantime, correct me if I'm wrong here, but what I understand is there is no prior authorization on MAT, but the real issue is the quantity limits. And so you need the latitude on the quantity limits to take care of this subset of patients. Is that correct?
That is correct, yes.
Okay. Yeah, no, I mean, I think that makes sense to me. I mean, the goal here is to make sure the patients have access to MAT. So, and I think the other piece of it is we don't want them on MAT and still getting large doses of opioids on the ACO side of things. So, I understand that's a part we can't as a group address. And so we'll have to work on that, I guess, at a future date. But your recommended changes, I guess, make sense to me.
Yeah, and just as a reminder, Eric, because I mean, I think we've mentioned this before, but there is a daily, so there's all the mental health medications are carved out to the state, in addition to MAT and a couple other classes of medicines like hemophilia factor and immunosuppressants. And there is a daily report that gets sent on the day following. So if patient received MAT today and it was billed through fee-for-service, there is a report sent the following day to the ACOs, which many of the ACOs are using. Some of them are integrating into their claims file, but they're using for like a retro DURB activity. So they'll bump that up against concurrent use, and this is one of the ways we're addressing, psychotropics, for example. And benzodiazepines and opioids, for example, because benzos are carved to the state. It's just not a real-time edit. So we could create edits on the fee-for-service side that may limit concurrent opioids and MAT, but those edits won't adjudicate real-time for ACOs. That's something that ACOs are going to have to do in a retro DURB fashion. But there is that report that is sent. So the data is received, a day later.
Yeah, and I think I need to actually have a conversation with some people internally to my organization as to how we're handling those reports. So,
excuse me, Eric, it's Sharon. Which when you say your organization, could you? This is the conversation that you all are having is I would say nearly 100% ignorant to what the implications are, and I really want to understand what you all are talking about process-wise, because I think this is extremely important, what we're discussing right here, and so I could stand to be a little bit better educated about the subtleties of what's being discussed. So could you help me understand a little bit better, please?
Yeah, I can try and help you understand to the extent that I understand.
Okay.
So if you look at Select Health, Intermountain Healthcare, our ACO has 100,000 members, roughly 95 something. And I think the issue is opioids are covered by us as the ACO or the plan, so that adjudicates through our system. But any Medicaid or MAT is covered through fee-for-service. And so those members are getting their MAT through the state. It creates this disconnect that I think at the time that we implemented the ACOs, it made sense in that mental health treatments and opioid overuse disorder treatments and things were covered by the state. The problem, I think, that is highlighted in the presentation today is as you try and get a holistic view of that patient and you try and make those edits and things happen real time at the pharmacy as a patient's getting therapy, it's very difficult. And so, you know, even though we get a report from the state that says the following patients got MAT, that's still, there's still an inability to load some of that information into the system that's real-time processing the claim. So you've got patients that are getting MAT that are also possibly through the ACOs getting opioids or other things. There's a real opportunity for people to game the system. And so you as a provider may think that the patient's getting MAT, and they probably are, but they could also be getting opioids. But then you've also got the dose limits and things that the state has put in place that could be in conflict with the processes that the ACO is trying to put in place. And so, I mean, legislatively, I mean, this is all a statutory requirement for the state of Utah. And so there's probably some changes that need to be made at the legislature to allow us to more holistically manage and take care of these patients. In the meantime, I think, you know, probably the best thing to do is make sure that patients have good access to MAT. And Jennifer or Mo, I mean, if I missed a point there or I misstated, you know, jump in.
Yeah, that's correct. And I mean, I think historically, as Eric said, it's the prepaid mental health plans, the medicines that were carved out tended to be managed by the prepaid mental health plans.
Okay, so that is extremely helpful, and and the other part, and make sure I understand this correctly as well. One of the things that's concerned me forever is that well, one of the things I would hope would happen is at a pharmacy dispensing window, some simultaneous prescribing of MAT and an opioid agonist therapy from another source could be caught at the dispensing window. But if a person's in a methadone maintenance treatment program where they're being dispensed methadone, that doesn't get caught.
That's correct.
So that has concerned me forever. And that is still the case, right?
I mean, that's federal statute that protects that.
Right,
you know?
right. But we have never been able to require that the MAT, if it's methadone plus now, you know, whatever might be being given to a patient under MAT in a standalone treatment program, we've never been able to require that those opioids be reported to you know, to the PDMP, so to the state controlled substance database. Right. So we have no safety net built in terms of reporting. I mean, even if the two things you're talking about got simultaneously fed in at a dispensing window, we still have we still have the other problem. So I was trying to understand. You said there's no legislative guidance from the federal act yet. So what I'm understanding is we're a little bit on our own right now. These things for I'm a little bit uncomfortable under the circumstances saying we should suspend or eliminate, you know, a psychosocial treatment requirement, given how much progress it seems we're making with, I'm just going to call it addiction treatment because it's what I think it is. and understanding, understanding where that puts us, it's kind of a double-edged sword. People do well long term if they're in programs, not just because they've been put on a drug. In my opinion, the best success is with people engaged in treatment. And yes, we want to save lives in a short term, but I'm wondering if there's some way, we can make exceptions on a short-term care, but if people aren't, I don't know how to do this. It's just a concern for me that we just suspend the requirement for comprehensive care and then give people long-term drugs that could be high-dose therapy with no expectation that, they get actual care. That just makes me really uncomfortable, especially when especially when the system would allow patients to continue to get MAT and concurrent agonist therapy elsewhere, and maybe on the back end we could see that that's happening, but we have no way to put safety checks in place. And that's probably all I have to say about this situation. Thank you.
I'd like to address some of the issues because I am a licensed Suboxone prescriber. First, the recommended change of discontinuing the psychosocial support. The most recent literature indicates that there's no consensus on what actually is the best type of psychosocial support or behavioral treatment, and that most of the current guidance really emphasizes that there are no barriers, including a need for any type of behavioral treatment, to accessing medically assisted therapy for opioid use disorders. And the psychosocial support can be something as simple as going to a 12-step program. That's sort of the state of the literature on psychosocial support. In terms of exceeding the maximum dose and quantity limits, I would, in addition to acute pain management and pregnancy, under rapid metabolizers, I would be a little bit more specific in that, at least for buprenorphine, it would be CYP3A4, and then with the norbuprenorphine, which is the active metabolite, you have UGT as the main enzyme system that is breaking down the active metabolite. And so someone who is, quote unquote, an ultra rapid metabolizer would be someone who has had some genetic testing that shows that. And then the concurrent use of the 3A4 inducers, I definitely do agree with that. On the part about allowing the single ingredient buprenorphine, there are a few other off-label uses that have recently been suggested in the literature. First, under hepatic impairment, I would specify mild to moderate, because if you, I believe that's Q criteria or Kyle's criteria A and B, because if you get into more severe hepatic impairment, you actually have to lower the dose by 50%, I believe. Other indications for the single use have been reported in the literature as renal failure, since buprenorphine is not substantially excreted in the urine, and others have been more recent sort of groups indicating that some populations in the elderly may benefit from use of buprenorphine as opposed to a full mu agonist, as well as individuals that where standard opioids have not worked. In addition, there are a few conditions under which you may see the combination used. And I know I was asked before this meeting to sort of look at that. And this is individuals who have perhaps an opioid use disorder that previously has not been addressed without, there are sort of three groups. And obviously those without pain, you know, need just regular MAT upwards of 24 milligrams a day. However, there has been some literature that suggests that up to 32 milligrams a day initially during the stabilization phase and dropping it back down further down the road. Also, opioid use disorder, in that case, there has been literature to suggest that using it similar to methadone, in which you have to dose it multiple times during the day, will address both the opioid use disorder and pain, as well as possible opioid-induced hyperanalgesia. So in those cases, you may see higher doses. Also, individuals may remain on an opioid. I know you gave at least two scenarios in the report. And another possible scenario for the use of a concurrent fairly high dose full mu agonist with buprenorphine would be for individuals who are tolerant or suspected of having opioid-induced analgesia, in which you're wanting to lower the total full mu opioid dose, and you're using buprenorphine in which to do that. Buprenorphine alone has also been characterized as a second-line treatment for chronic pain without opioid use disorder. So in addition to the indications for which you've put up on the screen, those are some other indications to look at. And although we would not hope to see children on buprenorphine, it should be noted that between the ages of, starting at the ages of 4 to 7, the clearance rate for buprenorphine alone is at least 3 times that of adult patients. So if for some reason they were using buprenorphine for whatever reason alone or in combination, that dose would also be higher. In terms of treating acute and chronic pain in patients on opioid use disorder, I know Dr. Weinstein probably would be better able to speak to possible options that are being utilized at the university or the VA. The only thing that starting to emerge is that you don't want to completely discontinue the buprenorphine or alone or as in some, you may need to reduce it to a very low dose, that being, you know, between 4 and 8 milligrams a day, but you don't want to completely discontinue it for someone who is needing to have pain, perioperative pain treated with a full mu agonist in the hospital.
All right. So, oh, sorry.
Go ahead. Go ahead.
So I know you suggested a couple suggestions to modify this. I know you said hepatic impairment, and it was just mild to moderate. And then there's a couple other ones. I know you wanted to be a little bit more specific when it came to CYP3A4 inducers. You were looking at the CYP3A4,
Well,
and then also
with the CYP inducer, it's actually under rapid metabolizers.
Yeah.
Because you want to basically, you don't want someone just at, you know, who has it at 1A2, 2D6, you know, based on, you know, a test that they did through ancestry.com or, you know, 21andMe or one of these, you know, genetic testing sites.
Right.
But often physicians, you know, we basically, patients come in and say, give us a whole, you know, battery of genetic tests that have been done. And really, that's one of the few ways we don't normally test for rapid metabolizer status in the absence of something like treatment-resistant depression that has responded to no antidepressants. But people will come in with, you know, low folate levels saying that's contributing to their depression, or, you know, I can't, you know, this medication isn't, I need a higher dose because my test says that, you know, it, you know, that the Prozac needs to be at a higher dose because of this genetic test, and those sort of things. But I think we need to be a little bit more careful with what we specify as rapid metabolizers.
So Sharon or Susan, I mean, let me ask you this question. I mean, the dose today is at 24 milligrams a day. And as the kind of the list of exceptions grows, or the specificity of the exceptions grow, it becomes more and more difficult, at least in my mind, for staff at the state to try and administer these exceptions, because they're trying to sort through all the material and information, and, you know, where did the test come from, and who did the test, and, you know, what exactly, you know, was the genetic mutation. Is there a recommendation to say, okay, today it's at 24 milligrams per day. If it went to 28 or it went to 30, and I am not getting the tablet strengths right, so, you know, my recommendation there on the number is probably wrong, but would it be easier just for us to raise that maximum dose quantity, or that maximum daily quantity, to say, you know what, if it comes in under 32 milligrams a day, we're going to hit 90% of the patients, and we're not going to have to go through all of these exceptions, and we facilitate the whole process. I mean, to me, it's I get lost in looking at all of these exceptions and things. More from an operational standpoint, you know, is there some limit or milligram per day that would make sense, that then we minimize the amount of work that has to be done on the other side?
Well, part of the issue with sort of the ceiling on 24 milligrams a day as opposed to going up higher is there does seem to be, possibly increased potential for diversion at the higher end of the dose spectrum. And as such, really, most of the literature says that, except under the, under certain circumstances, going above the 24 a day really is fairly uncommon. And the only times really that they're seeing it is initially in needing to stabilize a patient, or in terms of, they cite higher quality of heroin and the new illicit synthetic fentanyl street. But they also say if you do allow up to 32 milligrams a day, you should have in place a diversion plan. So the maximum dose approved by the FDA is 24. Off-label, they do go up to 32, but it's, it's not something that's very common. At the VA, I saw it maybe on one occasion with someone who was using heroin as opposed to prescription opioids. And so you may want to leave it at 24, and then if they want to go up above that dose, have, some sort of rationale for it. I'm not sure what you'd like to do with that.
This is Sharon. I see under our recommendations, these are for prior auth. We have acute pain, which is time limited, and pregnancy, which is time limited. Then we have rapid metabolizers, which this is a genetic, we're saying this is a genetic feature, which would be indefinite. So this could be a, unless we put a prior auth that has some kind of repetitive feature in it. This is somebody who might be on, doses above 24 indefinitely. And if they're on a concomitant drug that's an inducer, then we have somebody who's on a high dose indefinitely. So I think Eric's question is, are we going to have a subpopulation of patients here on high dose buprenorphine that goes on indefinitely? I'd be concerned again. This drug is abusable. This drug can be diverted. I think that, whatever the literature says, opioids are abusable and they're being diverted. And this one is, in my view, whether it's below 24 or above 24, certainly the more pills you give somebody, the more likely they are, to have extra to share and divert. So I think that's the point. But I think, the question is from the logistics, what's the volume? And I don't know the answer to this because this is not what I'm doing every day. So I would have to defer it to, other, the real experts in this area to say, how much work do you think this would be? And is Eric's suggestion a good one to just say, raise the quantity limit and let everybody just run people up to 32 when they want to, without any prior auth?
Just to be mindful for the time, we have about 7 minutes, and we still got to do public comment as well.
Yep.
So I think that's the question. If we think Eric's suggestion, we should go with that, or then we go through these changes. I would not. I would like to keep a hard boundary around this and not say that we're addressing pain management with buprenorphine in this. That is a very complex area, which I appreciate Dr. Siegfried's expertise on the OUD aspects of this. and we're really not addressing pain, or hyperalgesia, which I think is a much more complex subject, which is not adequately addressed either.
Well, I apologize. I was actually given questions by the pharmacy team prior to the meeting, and that it did include what would be an appropriate approach to treat both acute and chronic pain.
No, you did, yeah.
I got those too. I'm just saying I don't think we want to embed these in this
Right.
prior. Yeah, thank you very much.
I agree with you, Dr. Weinstein. Thank you.
All right, should we take public comment now?
Don't believe we have any
No? Okay.
public comment. So going off of the chat that is going on,
Mm-hmm.
so if we accept these,
Well, and Mo, why don't I just kind of move us along? I mean, I would move. I mean, I think what we've heard is the importance of psychosocial support. You know, it's a recommendation that we look at that, but I think, you know, what we've heard is that is critical as far as treatment for these patients, that they maintain that psychosocial support. So I don't know that we want to remove that. You know, I'd make one of two recommendations. Either we just wholesale increase the limit to say 32 milligrams a day, if that's the right number. And like I said, I don't know what the right number is, or we accept the recommendations to allow exceptions. I mean, I think the goal here is, and I think that, you know, going from 24 up to a higher number, yes, we increase kind of the risk of diversion, but I think the bigger issue is not so much the diversion as making sure that people have the support programs they need and they can get access to the medication they need. So, you know, whatever way is easiest to meet that goal, I guess, is what I'm saying I support and would recommend we do.
Hey, Eric, I was just looking at the presentation that Val put together and looking at the 2019 SAMHSA guidelines. It just speaks to that, yeah, every once in a while there is the 32 milligrams per day dose that is needed, but most of the time, it says rarely, or I guess 24 milligrams, it's unusual, but there are some rare cases. So I see putting the 32 milligrams in the form to help us kind of alleviate having the Medicaid team to work through the prior authorization. I don't know if it's going to increase more diversion or the opportunity for diversion, but it seems rarely that it's used over 24 milligrams. Would it be, like, I guess, is there documentation or do we have any history to look at prior use of patients over 32 milligrams to see if this is going to put more work on our team, or if there is that increased risk of diversion?
I think on our end, it might make more sense to keep the limit at 24 and take those exceptions where 32 milligrams is needed on a case-by-case basis. And as we get those requests with the clinical rationale, if it's appropriate, we would make that exception, but not do it as a blanket thing of opening it up to 32 milligrams as a ceiling for everyone.
Okay, so Brian, I think with that, given that we're like 1 minute from the end of the meeting, I would recommend that we accept these recommended changes for exceptions. I would also recommend that we maintain the requirement for psychosocial support, but in the event, given the current situation around COVID and everything else, if someone can't access psychosocial support, that should not be a determinant that it has to be met in order for them to get treatment. And so I guess in addition to these recommended changes, I would just say that if given the current environment and the situation we live in, everyone can access psychosocial support, they still be allowed access to the treatments.
This is Sharon. I agree with that. Is there a way to modify our language, or is there a way to? I was trying to think of a having it both ways, so to speak.
Mm-hmm.
Is there a way to initiate MAT on a time contingent basis for psychosocial therapy, or lacking that, say, you know, of course, psychosocial treatment is strongly recommended. I don't know if it could be done on, you know, those was it 13% of people who dropped out of treatment, or 13% of people had MAT on a one-time script. I mean, you know, I don't know if we have data that that show that you know, maybe those are folks who aren't, you know, as likely to have comprehensive care. That would be really helpful if we knew that. Then it would, you know, bolster my belief that comprehensive care has better outcomes. And Dr. Siegfried obviously knows the data much better than I do. So, you know, I'm just wondering if there's a way we can modify the language somehow, or make this strongly recommended, or.
Joe has proposed some language that might work. He wrote a plan for psychosocial.
In the chat here. Let's see.
Yeah.
Yeah.
A plan for psychosocial support intervention, or the rationale for the lack thereof.
This is Beth Gargaro. A concern I have about that is the number of prior authorizations we may end up with, especially given the COVID situation and not being able to access group meetings and people having difficulty accessing therapists and not knowing how long that's going to last. And, you know, I think possibly having language that psychosocial support is strongly recommended, but not using that as a criteria for accessing treatment.
Yeah, I agree with that.
That's what we just said. Not making it a requirement, but having it be strongly recommended, versus having it as a contingency somewhere down the line. I don't know how to do that, but I hate to just drop it out as if we don't recognize how important it is. And we're talking about only the high dose patients now, because we have no requirement for it in ongoing therapy with any dose below 24 milligrams. Is that correct?
Yeah, we strongly recommend it for moving forward. That's what we recommend moving forward, that for patients who are on that therapy, we recommend that. But we did not think about the part for patients above the 32 milligrams, because that's, according to the report, it's only used for a short-term basis. And so that's why we could definitely consider requiring a psychosocial support there.
Yeah, I think that makes sense to have Joe's language, a plan for psychosocial support or the rationale for lack thereof for those high dose that have to submit a prior auth.
Okay.
I mean, that includes some indication, like whatever referral they're being made, or, you know, identifying resources or whatever it is.
Exactly.
It's not withholding MAT. It's just saying you're trying to do what you can to get the patient to therapy or support.
Right, and I like that language versus the details of the support that they are receiving.
Right. So I think we have a motion on the table from Eric. It has not been seconded, but it sounds like there's some interest in modifying that motion. Eric, would you be interested in accepting a modification to your motion?
I would move that I accept that the modifications be made.
Would you
Okay.
restate the motion in its complete, just so we have the
I will try.
clear?
I'm not going to guarantee anything. I would recommend that we accept the modifications here to allow people to accept or exceed the maximum dose requirement, and that psychosocial counseling be a strong recommendation, but not a requirement to move beyond this.
Okay, is there a second on the motion?
Seconded.
Okay, ready to vote? All those in favor say aye.
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 Any opposed? And any abstentions? Okay, the motion carries. Thank you. So,
Point
go
of
ahead.
clarification, sorry, on the prior auth. So this has a what time period?
For implementation,
No, so this goes to, or did we say no, this is 3 months, 6 months, 12 months?
oh, I believe our current form.
Current form says authorization up to 6 months, and then it says induction
Okay.
phase and temporary pain management up to 14 days, and then reauthorization up to 1 year. The form I'm looking at here from
Thank
the
you. I
printout.
lost track of it. Thanks.
You're welcome.
Thank you.
All right, looks like that's it for our agenda, and our next meeting is Thursday, May 14th. Is there a motion to adjourn our meeting?
Move to adjourn.
Can I
Second.
thank the staff and everybody for excellent background work on this? I know it's a huge topic, and I really appreciate everybody's excellent work.
Yes,
Thank you.
agree.
Thank you.
Thank you.
Thank you.
Have a great day, everybody.
Thank you again.
Bye-bye.
Have a great
Thanks,
one.
everyone.
Thanks. Bye.